Dr. Shivan Sandberg-Lewis is with us today. So we love to learn from him. And what that means is that we have, as I like to say, 40 years of gastroenterology experience in an hour. And he has contributed so much to the community of naturopathic understanding of the digestive system with all of his SIBO work. And today we're also going to talk to him about GERD. And he is here with us, coming in live from Portland, Oregon. Hello, hello.
Hi.
Hi. Okay, so Dr. Seebecker and I were talking about what we wanted to do for the summit and the topics that we wanted to discuss. And of course, GERD was on the top of the list. She's like, oh, you got to talk to Stephen about that. So if you would, for people who are like, GERD, doesn't that mean I have to take Tums? Would you just describe what GERD is and what some of the negative ramifications are of it? What's the problem with GERD?
There are a number of problems with GERD. So GERD is short for gastroesophageal reflux disease. Some people have reflux, which means, in this case, it means backward movement of fluids through the lower esophageal sphincter, which separates the stomach from the esophagus. And that reverse flow will bring really irritating substances, assuming the person can make stomach acid. It will bring very irritating acid, possibly bile, because some people also have reflux that goes from the small intestine into the stomach and then into the esophagus. We can talk about that later. That's called D-GERD, because you've got the duodenum in there. And all those irritating substances can cause lots of symptoms in the chest and in the throat. And they can also lead to more serious diseases like reflux esophagitis, Barrett's esophagus, dysplasia, and even a cancer of the esophagus. There are other kinds of reflux too, which we'll maybe talk about some other time. The ileocecal valve, where you have ceco-ileal reflux going from the large intestine into the small intestine. And that, that causes problems too, like SIBO.
Right. And then you were talking about that there's even a third one.
Yeah, well, when I talked about D-GERD,
oh, okay,
that's gastroesophageal reflux. And that's when there's reflux of fluid from the small intestine up through the pyloric valve that separates the stomach from the duodenum. And then if that further refluxes from the stomach into the esophagus, gastroesophageal reflux, then you're getting bile and acid and enzymes coming up into the esophagus. And that is a real serious list of irritants.
How could someone get any of these conditions? Is it physical, like adhesions, or is it genetic? I mean, what is usually predisposing people to having any or all of those GERDs?
There is a myriad of causes. Probably the easiest way to describe it would be either a problem with the lower esophageal sphincter, if that little round tubular muscle thickness at the bottom of the esophagus isn't staying closed properly, then you'll get more reflux from the full stomach up into the esophagus. That's one thing, and there are a lot of things that can do that can cause that laxity of that muscle. And then the other big thing is more pressure in the abdomen than in the chest. And SIBO, unfortunately, is one of those things that causes a lot of pressure from all the gas pushing up against the diaphragm and creating more of a tendency for things to rise upward instead of to go downward.
So that leads to, well, what do we, that's the problem. What do we do about it? With PPIs or proton pump inhibitors being just handed out like candy. And I say that from my own personal experience because I was on them for 7 years at least. And prior to that, I would eat Tums like it was, you know, like nacho chips. I mean, I just was like piling through a couple of bottles a week. So what's the typical way that people in, let's say, America, around the world deal with it? And then what's some alternative ideas to maybe have a healthier approach?
All right. So first of all, there's the antacid, like you were talking about, Tums, and other calcium carbonate, other forms of minerals that will absorb acid. Problem with Tums and other calcium carbonates is that calcium salts, along with dairy protein and the calcium in the dairy, are some of the most potent stimulators of gastrin. Gastrin is a hormone that's produced in the stomach that actually stimulates more acid production. So when people eat calcium carbonate Tums, it takes a lot of acid to absorb calcium carbonate. So it absorbs acid and symptoms improve. But then the calcium carbonate stimulates gastrin production so that you produce more acid, and you get into this vicious cycle of producing more and more acid. It's called rebound hyperacidity. The same thing happens with a proton pump inhibitor or the older medicines, things like cimetidine, Tagamet. Those were the first ones that were introduced after the calcium carbonate, the Tums. Those would inhibit the H2 receptor on the parietal cell. The parietal cell is the type of cell in the stomach that produces acid. And the parietal cell responds to 3 different stimuli. One is gastrin, and the H2 receptor means that H stands for histamine, which a lot of people get a lot of interest in and study in the SIBO field. Histamine is also a stimulator to acid production, specifically the H2 receptor. There's a H1 receptor that has more to do with more allergic reactions on other tissues. And then there's acetylcholine, the major neurotransmitter in the parasympathetic nervous system, which is the rest and digest nervous system. So either acetylcholine, histamine, or gastrin, all 3 of those things can stimulate acid production. So, you know, in different times, different drug companies have gone and tried to attack different mechanisms. And so they've done the H2 receptors, things like Tagamet. They've done, they've not attacked acetylcholine really directly for reflux, but the calcium carbonate was just an initial phase to just try to neutralize acid, but it actually stimulated more gastrin. So gastrin got involved in that one. So what can you really do about it? These medicines have their place. Usually we use them for short periods of time, 6 to 8 weeks, to help heal ulcers or reflux esophagitis, when someone has a lot of irritation and redness and inflammation in their lower esophagus. So sometimes we'll use these things, but what else can you do? Well, you can treat the cause. That's what I like to do. Treat the cause and then gradually withdraw the medicine. So we have to talk about causes. Want to do that?
Yeah, let's do that for sure. I'm taking notes.
Okay. So like I said, the 2 main mechanisms are either the lower esophageal sphincter isn't having good tone, maybe the pyloric valve at the base of the stomach isn't having good tone either. And then there's pressure that's higher in the abdomen than in the chest. You know, the diaphragm is a dome-shaped muscle that separates everything that's in the thorax or chest from everything that's in the abdomen. And if the pressure up against the diaphragm, if the intra-abdominal pressure is greater than the intrathoracic pressure, you're going to have things being pushed up instead of moving down. And the third piece, which I think has been talked about a lot in this series, is peristalsis, or, motility. So if someone has poor motility, for instance, the most extreme case is gastroparesis. Has anyone talked about that yet in this?
Not so much, not enough.
Okay, so gastroparesis paresis means weakness. It's not total paralysis where things won't move at all. Weakness, and gastro, of course, being the stomach. So when the migrating motor complex, the first phase of it, and everybody in your group here knows about.
Let's just do a quick definition because we have new people all the time.
Okay. Migrating motor complex is a reflex that is very important in prevention and treatment of SIBO and most other problems in the gut. It starts in the stomach, and then it contracts things, contracts the stomach to empty the stomach. And then once the food gets into the small intestine, it contracts, different phases of it contract the small intestine to move food all the way down, food and bacteria, all the way down to the ileocecal valve, the very end of the small intestine. So it's actually moving things about 18 to 20 feet through the digestive tract. Remember, Dr. Seebecker and I and Dr. Shaver, we all teach a course called Advanced Gastroenterology at our university. And I wanted to call it The Small Intestine is Not Small. I still want to we call it that as sort of the subtitle, because the small intestine, it sounds small because of its name, but it is the longest, and it's not the most important because the whole thing is important, but it's extremely important, and it's 18 to 20 feet long. The migrating motor complex is moving food and bacteria and debris and fiber all the way down from the stomach to the ileocecal valve at the end of the small intestine. And when that first phase isn't working properly, the stomach can hold on to food for many, many hours. Normally the stomach is about 91% empty by 4 hours. And it's really dramatically more than half empty within 2 hours. In gastroparesis, or delayed gastric emptying, I had one patient, it seemed like it took about 10 hours for him to empty his stomach. And those patients, when they have extreme gastroparesis, they have terrible nausea and often vomit their food because the meal that they ate last time and perhaps the meal they ate before that is still in their stomach when they eat another meal. So they don't really want to eat. They have very little appetite. And this is caused by a lot of things, but probably the most common one is either post-infectious, like post-infectious IBS, when we talk about antivinculin antibodies and things like that, or blood sugar problems, diabetes and prediabetes. We see people whose autonomic nervous system, the parasympathetic is part of that, doesn't work properly. It's called autonomic neuropathy. The nerves have a pathology, and it's the autonomic nerves, the parasympathetic nerves, that are not working properly, and stomach doesn't empty. And then, of course, motility in the small bowel might also be pretty poor. And these people that's why it's come up over and over again that blood sugar problems like diabetes are a major cause of SIBO. And until you get the blood sugar working right, the nerves aren't going to work right. And you're not going to get rid of your SIBO. You're just going to keep having it because of poor motility.
Okay, so one more time, if you have the diabetes or pre-diabetes, that affects your nerves, and
Yes.
that affects your nerves, and then that affects your motility, kind of like if you have post-infectious IBS, meaning after a bout of food poisoning, and how the MMC is then inhibited because of the nerves. Is that right?
Exactly.
Okay. I know this is going to sound crazy because, you know, I've done about 100 hours of these interviews.
Yeah.
I don't remember. I do have brain fog sometimes, but I really don't remember ever hearing about the connection between blood sugar, diabetes, and gastric emptying. And maybe we just really haven't talked about that level or that height of the digestive system, but that is so interesting.
Yep, that's really central. And then if you want to put something on there that kind of often goes with type 2 diabetes and prediabetes, not always, and sometimes goes just by itself, and that's abdominal obesity. So, you know, apple fat or visceral fat puts a lot of pressure on this is not the subcutaneous fat that's just under the skin. This is deeper. It's around the viscera or the organs in the abdomen. And not only does it create lots of havoc in terms of the physiology and the functioning of the liver and other organs in the GI tract, but it also increases the intra-abdominal pressure by pressing against those organs. And that increases the risk of reflux. So when you can reduce the amount of visceral fat, that can really be a cure for reflux.
So when you hear about people who've lost weight and therefore their reflux is diminished or like goes away, is that usually the driving force behind that?
Well, it could either be that they had blood sugar problems and losing the weight helped normalize their autonomic neuropathy that they had from the blood sugar issue, or it could also be that the intra-abdominal pressure is lower. And it could be that once you lose the weight, your SIBO improves, and then you don't have as much pressure from the gas being produced within the lumen of the intestine.
So how is weight loss, I think I know the answer to this, but how is weight loss related to an improvement in small intestinal bacterial overgrowth? Is it that fat, the visceral fat has shrunk, and so therefore it's less pressure, therefore the valves won't open as much in a backwash?
I think that makes sense, but I'd probably put it more into the nerves and the sugar. Now think about it. When a person's blood sugar is elevated, there's going to be elevation of secretions in the GI tract as well, which feeds the bacteria and yeast. She's making it interesting.
I'm making lots of faces. Like,
So
what? That sucks.
yeah, and that's why diabetic women are very prone to vaginal yeast infections, because their vaginal secretions have more sugar in them too, and that feeds the yeast. Yeast is always there. It's a normal inhabitant of the vagina, the digestive tract, but it overgrows. So why, your initial question was, why would losing weight lead to improvement in reflux? Yeah, so change in pressure, and then also change or improvement in peristalsis, migrating motor complex, all those functions that occur through the enteric nervous system and the parasympathetic tone of the enteric nervous system.
When a woman diabetic or not, but oh, let's say a woman, estrogen levels change at a certain age and they start getting the abdominal fat from like perimenopause and menopause. Does that also lead to what we're talking about?
Yeah, it's, you know, age is one of the risk factors for type 2 diabetes. Kids have it now, unfortunately. 1 out of 3 kids born after 2000 will have diabetes. But, you know, if we just look at the way things have been for a long time, interesting thing is, if you look at some of the literature that talks about the way estrogen functions, one of the major ways that estrogen functions and does all the things it does is it affects serotonin receptors. There are 7 or so different types of serotonin receptors. 2 of them in the gut control motility in a large way. And that's the 5-HT3 and 5-HT4 receptors. And it's thought that estrogen really modulates or controls the function of those serotonin receptors. So that's how estrogen does a lot of what it does, is by interacting with serotonin. And we know serotonin is the major, it's the major thing that controls motility in the gut, besides motilin and some others that it works along with. So when you go through menopause and your estrogen levels are coming down, number one, Zatis Karazian has talked about this very eloquently, especially when estrogen levels drop precipitously, rapidly. That can trigger a lot of inflammation in the central nervous system. And inflammation in the central nervous system does not shut off easily. Once it's started, it just keeps going. And, you know, that will affect motility in the gut as well, because part of motility is, at least there's an input from the central nervous system to the enteric nervous system for that. There's a lot of crosstalk between the two. So anyway, going through menopause, there are a lot of mechanisms, maybe more than I should even get into, because I'll get too nerdy about it. But there are a lot of mechanisms that could turn on problems with blood sugar and therefore digestion.
Okay, so that leads me to antidepressants. I know this is a rabbit hole, but I'm okay with this because I really think a lot of people are dealing with this. Those, I don't know, are they called SSRIs? Is that what they're called? Those serotonin uptake things?
That's the original group, and now we have the SSNRIs also that affect not just serotonin, but norepinephrine as well.
Did your light go out?
The sun came out.
Oh.
And so there's sun coming from over there.
I was like, man, that lighting really changed. Oh, well, we'll continue. You still look wonderful. So is the SSNR, is that like Wellbutrin?
I believe so, yeah.
Okay. Well, so
those things modulate serotonin receptors as well. Well, at least they affect the reuptake of serotonin from the neuronic space and make a stronger serotonin effect.
Is this possibly one of the connections between the brain and gut, and how, I mean, is this where they're saying that people, and this is such a reach, but people with the altered microbiome could be more prone to depression and mood disorders? Is that the same deal?
It's a real thing.
Yeah.
And it is true that even, digestive problems can definitely cause or add to depression and anxiety through many mechanisms, which I love to get into if you want to, but maybe you don't want to.
Yeah,
the actual mechanisms, but try to make it more practical.
well, and it's also like, then would it be also the reverse? So you are depressed, and that leads to more digestive problems. You have digestive problems that can lead you to being more depressed. That's depressing. That whole thing I just said is depressing.
Yeah, we call it crosstalk. It goes both directions, from the central nervous system to the gut and the enteric nervous system. And the enteric nervous system is interacting very intimately with the microbiota that make up, you know, the yeast, the bacteria, the viruses that make up the GI microbiome.
So let's say you are diabetic, you're pre-diabetic, you might be a menopausal woman or perimenopausal woman. What's your best advice for improving the digestive system? And then we'll circle back to GERD. But what's your best advice in this sort of lane about how to help your digestive system?
Well, first of all, it would be to do the things that make your blood sugar healthier, your blood sugar balance healthier. So that's going to be daily exercise, something you like to do, preferably. Like walking is terrific, especially walking where you're not carrying anything and your arms can swing, cross crawl. Yeah. Because that does a lot of beneficial things. There's actually a book called Walking Your Blues Away by Tom, lost his name. Walking Your Blues Away by Tom, anyway, he is a psychologist who has written a lot of books. This one is just how to use walking as a way to clear emotional trauma. Just as you might use EMDR with eye movement, this is using your whole body in a cross-crawl movement to help clear trauma and, you know, unresolved emotional states. And Tom Hartman, I'm sorry, just remembered it, Tom Hartman. And yeah, we use these kinds of things. So walking has a lot, and any cross-crawl exercise has a lot of benefits. By the way, riding a bike is not cross-crawl because your arms don't swing unless you ride without holding the handlebars, which I don't recommend. Cross-country skiing is terrific, and any of the machines that do that sort of whole body, yeah, get the arms moving opposite the legs, stair steppers and stuff like that. But anyway, that's one really important thing that helps blood sugar. It can help with weight loss. Another really important thing is the thyroadrenal, which is something I made up. The thyroid gland and the adrenal glands are so important in normalizing blood sugar, maintaining bone mass, helping with mood and energy and blood sugar. Very, very important, and blood pressure as well. Those glands are so important for the maintenance of normal function. And so often in standard medicine, the only time you really look at the adrenals is when there's 90% of their function gone. That's called Addison's disease. It's very rare. It's an autoimmune disease. Or when a person has Cushing's disease, which is when their stress hormone cortisol levels are so high that everything goes haywire and you can actually die from it. Very serious condition, which is a little more common than Addison's. But in naturopathic medicine and other forms of natural medicine, we like to look at the adrenals before they're 90% gone, because many people have a lot of dysfunction there. And you can't really, in my book, you can't really separate thyroid from adrenal. They work so closely together. So that's my suggestion, is balance your adrenal and thyroid function so that your blood sugar can normalize so that you can lose the weight around your waist, because that's one of the better ways that we have of measuring abdominal fat, or that kind of apple fat, is the waist circumference. For women, over 35 inches is too much. For men, over 40 inches is too much. And so it's easy enough to say, oh, lose that waist circumference, bring it down, just get to it. Well, that can be almost impossible if your insulin levels are very high and your DHEA levels very low and your cortisol is very high. That's the worst group of hormonal levels that can lead to a waistline that just gets bigger and bigger, and you could lose weight all over your body. Your face might look emaciated, but you can't lose the weight around your waist. And that's the weight that's controlling the whole blood sugar issue, which causes GERD and causes SIBO and other digestive problems. So the thyroadrenal, if you would, gland is really important there.
How do you spell your new word, thyroid?
Oh, you probably don't want to. You probably don't want to make it a real word. It's not. It's just my way of letting my student doctors and my patients know that it's from my way of thinking, it's a little superficial to be treating somebody's thyroid and ignoring their adrenal, or vice versa. You have to look at both. Even just to improve the conversion of T4 to T3, T3 being the active thyroid hormone, T4 being having a little bit of activity. Just in order to make that conversion, you have to have a good balance of DHEA and cortisol. So that's really important.
It seems like hypo and hyperthyroidism, or thyroid scenarios, is practically an epidemic these days.
Hypo is hyper, I don't know if it's a 10th or a 12th of the amount, but yeah, they're both big deals. And that's in part because of our environment, because we know that xenoestrogens and other environmentally produced hormones, often from plastics and phthalates, those are ubiquitous in our environment, and they tend to affect the thyroid. And so if we could just do one shout out, if this has not happened before in your series here, men and women, especially women, please don't drink water out of those crinkly, soft plastic bottles. Yeah, like that. Don't do that. Don't do that. Stop doing that. Because you're getting phthalates, you're getting plasticizers that make the plastic soft and pliable. You're getting those when you're drinking it, especially if it's sat out in the sun and got too warm, and then even if you cool it off again, you're getting factors that are throwing your hormone balance off in a major way. And it's totally avoidable if you can avoid those kinds of plastics as much as possible. The other big piece of reflux is diet, right? Even if you don't have SIBO causing all that intra-abdominal pressure, diet is a big factor. And so there's a book called No More Heartburn. And I'm really forgetting author names today.
That's okay. That's what Amazon is for.
I'll think of it in a minute. I don't actually, it's not my favorite book, but the first chapter is on heartburn. The first chapter is quite good. And I've adapted some of this information. Sherry Rogers is an MD who wrote this book. And I've adapted some of this information in my textbook. And I'm going to be writing a book on reflux in the next couple of years. I'm just getting started on it. But her she has a little mnemonic called "Cut Out the Crap." Cut out the crap, C-R-A-P. And I've expanded what those things mean a little bit as well. But I thank Sherry Rogers for this really nice foundational idea. So the first C, the things you want to cut out, the first C is cigarettes, tobacco, and cola or other soda. We know that that's a big factor, especially with the high fructose corn syrup, but even if it's sugar-free. And then C also stands for chocolate, because all the methylxanthines that include theobromine in tea, caffeine in coffee. Oh, I didn't say coffee yet, did I? Mm-mm. And theobromine in chocolate, all those methylxanthines can be factors that irritate the stomach and trigger more reflux. So chocolate, coffee, cola.
Cigarettes.
And then the R in cut out the crap is for refined carbohydrates. Even though we tell people if you're losing too much weight when you're treating your SIBO, you want to try using some white rice and see if you tolerate that. There are some white rices that are not as processed, just polished a little bit, as opposed to white flour and things like that. And really, on my cut out the crap handouts, I say refined carbohydrates or too much carbohydrate. So we know that a low carbohydrate diet can really almost instantly improve reflux in a lot of people. And maybe that's because you're not feeding your overgrown intestinal flora as much substrate to make hydrogen and methane and hydrogen sulfide from. But whatever the mechanism, a lowering of the total carbohydrate seems to help reflux in a lot of people. And A in cut out the crap is aspirin and other non-steroidal anti-inflammatory drugs like ibuprofen, aspirin, naproxen. And then you could also put A for alcohol. Doesn't mean people can never have alcohol without having reflux, but it's definitely a factor that affects the tone of the sphincters and is irritating to the entire gut when it's too concentrated. And then P is for processed food in general. Or you could put soda pop there instead of under C, because it's not just cola. And I also added packing in food at bedtime under P. Because if you eat much food, within 3 hours of laying down at night, remember I said it takes about 4 hours for the stomach to be completely empty if a person doesn't have gastroparesis. And so 3 hours gives you time for a good 70 to 80% of the stomach to be empty for most people. And so there's going to be less pressure when they lay down for there to be reflux into their esophagus from their stomach. So cutting out the crap, getting your thyroadrenal working so that your blood sugar normalizes, and exercising in a way that you enjoy and that is rhythmic and sustained is, those are some big deals. And then, I guess we should, when we say cut out the crap, we really should have, one of those should be eating too much at a time. So maybe A is for appetite. Listen to your appetite. And after you have one helping of food, wait at least 20 minutes. Go do something that takes 20 minutes before you decide if you're still hungry enough to have seconds. And slow down. If you eat your food slowly and chew it slowly and thoroughly until it's liquid and then swallow it, by the way, if you haven't done that, you'll find that your muscles will naturally be trying to swallow the food really way before it's liquid. And you have to slowly you have to think about it the first few times you do it and really concentrate on not swallowing the food until it's fully liquid. And my wife, who is a stress management coach, she has a really smart saying, and that is, you have to fool your body into thinking you're safe. And the best way to fool your body into thinking you're safe, so it doesn't go into a fight or flight response while you're eating, is to chew your food slowly and thoroughly until it's liquid. Because your brainstem, base of your brain, is always monitoring the environment to see, is this dangerous? Do I actually have time to chew and swallow my food, or do I need to run because something's going to kill me? And you know, your brainstem, it's very simple-minded, you know, it's very primitive, and it's just always thinking about that sort of thing and trying to control heart rate and breathing and all these other things. And so you can fool your body into thinking you're safe so that it will allow your parasympathetic nervous system to get the gastric acids flowing, to get the pepsin flowing, to get the mucus flowing, to get the pancreatic enzymes flowing, everything working and motility working, if your body thinks you're not about to die. And your brainstem really responds to that. If you're chewing your food really slowly, it figures, oh, this person's got all the time in the world. I guess there's no predator around. I guess we can really focus on digestion instead of fight or flight. Let's get the hell out of here or kill whatever it wants to kill us.
And isn't it like if you are in fight or flight, isn't like one of the first things that happens is your body just stops digesting to use that energy to be able to run away?
Yeah, it shunts the blood to the brain and the muscles in your arms and legs so that you can do those things. Instead of having almost 50% of your blood pooling in your abdomen dealing with the food.
So do you need to train your brain every time you eat, or is it one of those things where it's kind of like a muscle and it starts to have more and more experiences of being relaxed when you eat, and then it's easier to have that relaxed sensation when you eat? Or is it like every single time you need to train it and tell it?
Well, it depends. It depends on your life. I'll tell you this. When I am in the middle of my day seeing patients, you know, I've seen my morning patients and I go and I take a half hour to eat or 40 minutes to eat. When I first sit down, the food's there, it's ready. I first sit down, I have to check in with myself. What a simple way to do this is just to get a sense of, am I feeling the chair that I'm sitting in against my body? No, I'm still hovering. You know, I'm just kind of tight. And so what I'll do is take a few easy belly breaths, which again, thank you, Kayla Sandberg-Lewis, for teaching me all these things over the years. And then I'll just sit and, you know, I know how to meditate, so I'll just do that for even 1 or 2 minutes until I feel my body settle down where I can actually feel like I'm supported by the chair. Then I know, okay, now I can eat. Also, another really simple thing you can do that's very effective if you don't meditate or want to do this in addition is just think of 1 or 2 things you're really grateful for. Grace before meals. Sounds like it's a religious thing, and I guess it is for some religions, but it's also, they came up with it because they knew it was good for digestion. Yeah, and you know, heart math, the folks that study parasympathetic tone and the way that you can encourage it, they say that feeling a sense of gratitude is one of the most potent ways to stimulate the parasympathetic nervous system. So yeah, I just sit down and I think, I'm so glad I have all my 4 limbs and they all work. And I'm so glad that, you know, my patients keep coming to me and we have this great time interacting and helping them. So, you know, it could be the simplest little thing. It doesn't have to be complicated.
You know, when the first time I met you, we were at Gary Weiner's office, and you know, we were there for all afternoon, and you were like, okay, I gotta go eat lunch now. And you went into another room. I don't know if you remember this. I do, because I'm very visual. I remember you were in the other room. You were just sitting there. You had like your glass, not Tupperware, but it was glass, because no plastic, thank you. And I think it was like a chicken breast or something. You had your cute lunchbox, and then you had your glass, and you were eating slowly, but not like overly slowly. It was just like you were present with your food. And you don't know this, but there have been many times that when I have been trying to be more present with my food, I've actually thought of you at Dr. Weiner's office in that exam room that was, you know, nothing was going on except you were eating your lunch. I've thought about that so many times.
That's great. It's great that I think that a good doctor is sometimes playing the role of Jiminy Cricket, you know, being your conscience on your shoulder. Oh, I remember, I'm not supposed to eat this way. I think I would rather do it this other way. And, you know, you kind of see my goofy little face when you're sitting down to eat and you're thinking, oh, I should slow down. I want to slow down.
Yeah, Jiminy. Yeah. So anyway, just so you know, random act that you didn't know had such a big impact. I wanted to circle back around in terms of GERD. You know, there's the whole take HCl / apple cider vinegar approach. How weigh in on those things, if you would, because they're very common DIY home remedies and controversial. At least when I went to my ear, nose, and throat doctor, the one who put the scope down there and said, "You're pre-Barrett's, Shivan." And I was like, "No, I feel fine." No, your entire esophagus is like cherry red down there. And I was like, "Really?" And then I started to think about it. Okay, yeah, I guess I do eat a lot of Tums, and it became very, he had to tell me what I was feeling, which is super strange. But anyway, and I asked him about the HCl, hydrochloric acid, and he's like, there is no way that HCl will be strong enough to produce in capsules a change in your acid levels. And plus that's adding acid. So no, he was like, just totally poo-pooed it. So then 3 times I attempted it, and the 3rd time was the charm. It actually did work, and I was able to get off my little purple pill after 7 years. So what was that, a fluke? I hear people do get a lot of success with it. And what do you think? What's your experience with that?
So hypochlorhydria is one of the causes of heartburn. And it's a complex mechanism, and no one knows exactly what the right mechanism is that does that, but it could be that having adequate acid production in your stomach affects the tone of the lower esophageal sphincter. We think it does. Also, having enough acid in your stomach helps to speed up the emptying of the stomach by triggering certain other chemicals. You know, if you have gastroparesis, almost always you'll find that people have achlorhydria or hypochlorhydria more commonly. They have low levels of stomach acid production, and their stomachs stay full a long time. It's possible to have high acid and also have your stomach not empty properly, but often if acid levels are extremely high, the stomach will empty prematurely. Again, there's lots of possibilities with this physiology, but I would just say that having the right amount of acid can help with the tone of the sphincters and with gastric emptying, and therefore could have a big effect on reflux. I don't usually give patients with Barrett's esophagus and reflux esophagitis, I don't usually start them off with hydrochloric acid. We have in our office at 8 Hearts, we have a Heidelberg machine, which is a way to directly measure stomach acid levels. And interestingly enough, if someone does have decreased stomach acid production during the test, my resident who does the test with the patient they'll give them a capsule of hydrochloric acid and see what that does to the pH, because you get an instant response to the computer from the stomach. You can see what the pH is at all times. And we see how many milligrams of betaine hydrochloride does it take to normalize the stomach acid level, to bring it where it belongs. And so, yes, capsules do, within a matter of minutes, change the pH of the stomach. We see that every day in our office. So I disagree with what the gastroenterologist said, but yeah.
He was an ear, nose, and throat guy.
Oh, ear, nose, and throat doctor.
Yeah, right.
They deal with reflux a lot too, because there's something called laryngopharyngeal reflux, or LPR, which is interesting because often those people they don't have heartburn. They just have symptoms in their throat. Mm-hmm. So it could be hoarseness. It could be having to clear your throat all the time. It could be a cough, a chronic cough. It could be swollen tonsils. It could be swollen larynx or voice box. So that's a whole different kind of reflux, but it can be caused by reflux as well. And one thing we haven't talked about is hiatal hernia. So hiatal hernia is a major cause of reflux and heartburn and LPR, all these things. It's when the stomach moves up through the hiatus of the diaphragm. Remember, the diaphragm is a dome-like muscle that separates everything that's in the abdomen from everything that's in the thorax or chest. And it has a little hole in the middle called the hiatus. And that's what allows the stomach that lives underneath here to attach to the esophagus through that hole, the hiatus. If you have a hiatal hernia, that's either a hiatus that's wider or for some reason allows the upper portion of the stomach to come up into the chest. Now you have a space-occupying lesion in your chest. You have something pressing against your heart, which can cause arrhythmia, including atrial fibrillation. You have something pressing against your lungs, which, if enough of the stomach is in the chest, I saw one of my patients had shortness of breath, and it was due to collapse of her left lower lobe of her lung, because her stomach, so much of her stomach, almost her entire stomach, was in her chest. That's kind of rare. I've only seen 3 patients like that in my career where their entire stomach is up in their chest, but it's very common for 2 or 3 centimeters of the upper stomach to be in the chest. And what does that do? I'll try to keep this as friendly and simple as I can, but the diaphragm is a muscle. It's a big, thin, wide dome of a muscle. In fact, for people that eat meat or have been to a butcher shop, it's called skirt steak. It's really thin, skirt steak. That's diaphragm, and as I understand it. And so this muscle, it's smooth muscle. It's not like a muscle that you control voluntarily, but it's smooth muscle that's under parasympathetic tone control and other tone from other parts of the nervous system. And it acts as the outer sleeve of the lower esophageal sphincter. The lower esophageal sphincter it's the muscles that are thickened right at the bottom of the esophagus where it meets the stomach. But in addition, is that a cat?
Yes, she's hungry.
In addition, we're talking about food.
Yeah.
In addition, the diaphragm, being a muscle, surrounds that hiatus right at the same level as the lower esophageal sphincter. So I like to call the diaphragm the outer surface. It's the outer layer of the lower esophageal sphincter. So if you take your stomach, which is normally here with the lower esophageal sphincter and the esophagus right at the base, right there, everybody's happy, they're working together, and you move the stomach up 3 centimeters, now the lower esophageal sphincter is at the top of my fingers, and the diaphragm's here, so they can't work together. So if you can bring it back down in its normal position, now you have a full lower esophageal sphincter. And a lot of what pushes the stomach up is everything we talked about. Increased intra-abdominal pressure, SIBO, holding your breath. Did you know constipation can cause hiatal hernia?
What?
When people have constipation, they often will have to strain to have a bowel movement. Or if you're having a baby, if you're a woman having a baby, they take push, push, push. And if you hold your breath when you're pushing to push something out, well, baby or a stool, you're greatly increasing the intra-abdominal pressure. So I train my patients after we do a manual correction with a deep, slow massage technique that brings the stomach back down. And then I tell my patients, you need to breathe before you contract your abdominal muscles. So if you're lying down and you're going to sit up, take a breath first and breathe out as you sit up, because you're going to have to contract your abdominal muscles to do that. If you are going to have a bowel movement, especially if you're constipated and you're going to be bearing down a lot, first take a breath. Breathe out as you bear down. If you run out of air, stop bearing down, take another breath. You'll find that that doesn't allow you to get as much pressure, but that's exactly what we want, is not to build up the pressure so much that you create hemorrhoids, hiatal hernia, intra-abdominal hernias, all those things. And then the third time that you really want to be conscious of your breath is when you're lifting something. So if you're lifting something more than 5 or 10 pounds, take a breath first and exhale as you do it.
This makes sense. How can someone find out if they have a hiatal hernia? Like, of course, because I'm the poster child for all this, of course, I have one too. And I found out when I did a scope this way, and my doctor said, different doctor, he said, it's not bad enough to have surgery, but it's enough to be like uncomfortable.
Yeah.
How else can we find out if we have that?
So the ways to find out if you have a hiatal hernia, one would be a barium swallow or an upper GI barium study. The other way is upper endoscopy, like you had. Very rarely I have seen it suggested that there was a hiatal hernia on an abdominal ultrasound if they went a little bit above into the chest. That's not a really reliable way to do it, apparently, but if they're interested enough, I guess somebody could possibly see it there. And it could be seen on a CT if they were looking for it. Although usually you get either an abdominal CT or a thoracic chest CT, but some people are getting both at the same time, and so it might show up there as an extra bit of organ in the chest that doesn't belong there.
So a physical maneuver can help that, like the old you do it and the old osteopath, move that some chiropractors still know. A visceral manipulation therapist could help with that too, right? Is that the only way that you can address a hiatal hernia?
As you discussed with your gastroenterologist, there is a surgery, and there are 2 other newer forms of treatment that are endoscopic surgery procedures. The most common one's called Nissen fundoplication, and it's a technique that's really kind of interesting, where they take the fundus or upper portion of the stomach and wrap it around the back of the stomach and then sew it to itself around the front. It's like creating a little turtleneck sweater around the top of the stomach. And it does hold it in place, and it mimics what I was saying about the diaphragm, because normally the diaphragm creates a little turtleneck sweater around the top of the stomach. So remember, anything you can do to strengthen your diaphragm could also help with reflux and with hiatal hernia staying in place. So singing loudly, gargling, things that you can do, especially loud singing and speaking loudly. I don't usually speak very loud, but it could be an exercise and breathing exercises, learning to do diaphragmatic breathing. There's a really simple, elegant exercise where you take one sheet of toilet paper and put it on the wall in front of you at the height of your face. And you stand 12 inches away and you practice each day and see how long you can hold the toilet paper against the wall just with your breath. Because you have to use exhalation, prolonged exhalation, and keep the force up in order to keep the toilet paper from falling to the floor. And that's a really nice little exercise for the diaphragm. Anyone who has asthma, reflux and asthma are like a cycle that go around and around and around for many reasons, interesting reasons. But, being able to become proficient in the use of your diaphragm muscles can help with asthma as well as helping with reflux.
So when you talk about the gargling and the loud singing, that reminds me of Dr. Karazian's exercises for helping strengthen the vagus nerve. So that's like a super duper double whammy bonus: help the diaphragm, help the vagus nerve. And would visceral manipulation, other than my little idea about the hiatal hernia, would that help with reflux as well?
Visceral manipulation, in order to help with the mobility of the organs in the abdomen, meaning their ability to move with respect to each other, move around each other, as well as motility to move things through the lumen or the inside of the tube. That's a big part of what it's all about. And especially bringing the stomach down back into the abdomen and keeping it there, and keeping that lower esophageal sphincter in line with the diaphragm so they can work together. That's really important. That's really effective.
So it's interesting that we're talking about this, of course, because these topics are very interesting, especially to anyone who has issues. But quickly, a little story about my visceral manipulation session that just happened like 2 weeks ago. We've been working on a lot of different stuff, and my therapist, I call her like a living CAT scan machine, because I'll ask her like, oh, what's that body part? And she can tell me, and she's like, oh, your ileocecal valve is slightly rotated, all this jazz. Anyway, she came at my stomach from a different way. And when I say came at my stomach, she was just like kind of palpating around and feeling around, and it kind of hurt a little bit more. Usually it doesn't hurt. None of her work seems to really hurt, which is fantastic. And she's like, wow, I really feel a lot of, she described it as sort of like tight, dry, these are just her descriptive words, not being literal, like fascia underneath. And it then explained my left shoulder blade pain. And then it also explained why even when I was a yoga teacher, right? So I would do this and that kind of thing. And I was always stretching my psoas muscle because I always felt like so compressed here. And I always thought, oh, my psoas is so tight. It was actually probably from 1991 when I was in a car accident and the car came at me from this way, the seatbelt dug into me and I went like this. And it probably caused a lot of adhesions and stuff under the stomach. That's my working hypothesis right now. But since we released that, holy smokes, I feel like I can breathe. I feel like I can do this, which doesn't seem like a big deal to people. But like if you can't do it and it doesn't feel good, then it is a big deal. And I just feel shockingly, totally transformed.
Happy to hear that.
Thank you.
It's Fascia is a much ignored part of the body that has multiple functions. And I also am trained in structural integration, so I'm intimately involved with the fascia. And it's amazing what can change so fast when you relieve an adhesion in the fascia so that you don't have a little spot weld anymore. It can open up and things can move and be as long as they're supposed to be instead of being all shrunken up like that. Yeah, it's great. And left shoulder is a common place for gastric stomach problems to reflex.
So I'm just sharing that with everybody because I've been getting body work since, well, the 80s, but the final frontier and the constant frontier for as long as I can remember has been that left shoulder blade. And I've had acupuncture needles in there. I've been Rolf 3 times. I've been structurally integrated. I mean, I've had it all done. And for the first time, like ever since my memory, I finally felt relief. And it was after that she gently released the adhesions underneath my stomach. So I'm just throwing that out there because if I took so long to figure that out for me, and this has been like a part-time job vision quest for me for most of my adult life because I've been in such discomfort. I hope this helps somebody out there to save them a lot of time.
Yeah, there are so many layers to issues that people have, and I know people have come to me and said, "Oh yeah, I've had visceral work and it just didn't help." How even if you ask how many times you went, well, I went. I had 20 sessions. Well, that's a pretty good number of sessions. That's a lot of sessions. It could be at the 21st session, it's just right, and the practitioner finally notices what's going on with that one little piece. You never know. It's a different day. You don't step in the same body twice.
Yeah, it was probably about our 30th session too. I've received tremendous help, and she's like, "Oh, I've been in this area before, but was never sort of drawn into it, and I never really felt a difference." And it wasn't like, "Oh yeah, that's a hot spot" or anything like that. It was just like, "Oh yeah, that's my stomach," and it was just like you said, right time, right place, answered prayer, whatever. But there it was. So, persistence is my superpower, my secret superpower. So anyway, good luck everybody, because I know this does take persistence and feeling well. Dr. Sandberg-Lewis, thank you so much.
It's been fun. Thank you. I appreciate it.
You are brilliant, sir. Thanks so much. And I know you've just helped so many people expand their brains. And first step, get that blood sugar level balanced out. Seems to be a fabulous idea for so many reasons.
Yeah.